Okay, students, so we've moved on to the processes and stages of labor and birth. Oh, we're going to have fun. Oh, this is terrible. So there's theories of labor onset, and these are some of those theories. Not one is, remember what a theory is. Not one or I would say they're all theories. So there's the uterine stretch. Oh, it's full. It's like your gas tank is full. Okay. And oxytocin, you should have learned in anatomy and physiology. It's released from the posterior pituitary, and when that gets at a certain level, then it initiates contractions, which initiates labor. Progesterone are decreased, then it's time to get the kid out. Prostaglandin cascade and the aging placenta. The placenta gets old. It's time. It's time. So labor physiology. So these are things that, yes, you definitely need to know. So we're going to talk about each of these separately, but each of these are important to the delivery of the infant, not one more than the other. Passageway, which is the pelvis and the pelvic opening. The passenger, which is the fetus, the size, and the placenta. The powers, the contractions, powers that be. The psychological fear, anxiousness, or excitement, and the maternal position. They all make a significant difference on the physiology of labor. So there's the first thing we have are signs of labor. Labor is about to happen soon. And lightning, that's where the baby drops into the pelvis, whereas prior it was riding up high under mom's ribs and kicking them. And so the baby dropped down into the pelvis. The baby has a drop, turns sideways, and then it drops down in. There's an increase in level of activity. Any of you that have had children, I know I cleaned my house like crazy the night before. So that's just the energy that kicks in. I don't think my house has ever been that clean since. Braxton Hicks contractions, we'll talk about those. I call those practice contractions. And ripening of the cervix, which is a show, it can happen 24 to 40 hours before labor onset. Remember earlier I called that popping your cork? That's where that plug is at the opening of the cervix. The plug is there and it is discharged. So there's a big difference between false contractions and true contractions. Sure, true contractions, they'll pick up, they'll get stronger gradually, slowly, but the big one is cervical dilation. So, in order for the fetal head to pass through, the cervix has to be 10 centimeters dilated. So we go from 0 to 10, but that takes some time to do that. One of the things, let's say the patient has called and we say, well, come in. She said she's been having contractions all day and she's really not sure. They're strong, they're uncomfortable. So we'll have her come in and we'll check her cervix. And that's something a provider can do. And also nurses are trained to do that as well. And when you check the cervix, maybe she's long, thick, and closed. We'll talk about each of those as well. Or she's 6, 7, 8 centimeters. So, or maybe she's closed. Closed means that the contractions weren't doing anything. There was really no change. And so therefore the provider might say, okay, I'm going to keep you for an hour or two and we'll let you stick around and then we'll check you. Because if the cervix, if she was truly in labor, the cervix would show some type of changes, whether it be effacement or dilation, within an hour or two. So the passageway. So not every woman has the same type of pelvis, believe it or not. We might all be women, but some things are a little different. So what we're looking for actually is what's called the anterior and posterior conjugate. That conjugate makes a difference on if the fetus can pass through the pelvis or not. So what is the shape of the passage? So that's what we look at. So the anterior and posterior, The gynecoid pelvis has the optimal space for the fetus to pass through, to pass into the pelvis. Okay, so you can see anthropoid does not really. It's kind of egg-shaped, but it's very narrow here. And platypoid doesn't either. An android is actually the male pelvis. So what we look at, the spots right here, this is the ischial spine. So we'll talk about that a while too. But just remember gynecoid. That's the favored pelvis that we want the woman to have. Most common, anterior, posterior, shorter than transverse, is favorable. Anything else, forget it. So the passenger or the fetus, the molding, remember those bones of the skull. There's 1, 2, 3, 4, 5 bones, and they cross over each other as they're coming out into the vaginal opening, into the vaginal canal. So that's important. How big is that head anyway? The stages of labor. So when I'm talking about the stages, there's a difference between the phases, as you'll see in here, and the stages. So if you're doing an exam like the NCLEX or final exam or any other type of exam or quiz, remember that makes a difference whether it's the phases of labor or the stages. So the stages of labor is from 0 to 10 centimeters. That's the first stage of labor. Within that stage, there are 3 phases. You call it's early or latent is another way to say it, octave, and transition. So between that 0 to 10 centimeters. The third, did I say? Wait a minute. Let me go back. Oh, stink. Sorry. Previous. Back down. Previous. There. This, okay. The first stage is 0 to 10 centimeters. The second stage is 10 centimeters dilated to birth of the baby. And then the third stage is the placental, delivery of the placenta. And the fourth stage is 1 to 4 hours following delivery. So those are all each separate. And really what this shows, remember I said it was latent or that early stage, actually takes the longest, is the longest part when there's never been a child through the passageway before. So everything has to stretch out, and oftentimes it goes slowly, just a little bit at a time. So it can take a while if it's the first baby. So then we have the passenger. Oh goodness. And stations. This is showing stations. So remember I said this was the ischial spines. So we're talking about labor. So we're saying that this infant has turned and it's come down in the pelvis. Well, maybe it hasn't. When the provider checked, one of the things that they're going to check is also the station where the baby is located. Think of it as a train station. The train stop is here at the spines before we start going out. So we want this infant to be as far down as possible when she's fully dilated. So -5, -4, 3, 2, 1, those are, they can be called floating. Anything that's minus is floating. It's still up there a bit. So +1, +2, +3, +4, the head is out. +5, we're delivered. So it makes a difference when your provider puts their gloves on and they're checking in the cervix, they're checking for dilation, and they're also checking what station is this infant at. And we'll talk more about that later as well. Also, what is the presentation of this passenger? Is it head down? So head down would be vertex position, head down. Butt down, of course, is breech. Most of us know that, right? So what these mean is ROA, right occiput anterior. So if you remember your anatomy and physiology, so the occiput is the back of the fetal head, right? So, and this is the maternal pelvis in facing the other way. This would be the right side of the maternal pelvis. So the back of the fetal head is towards the right side of the maternal pelvis and is facing forward, which is anterior. So right occiput transverse is it's sideways. Right occiput posterior, the back of the fetal head, is facing towards the back of mom's pelvis. This is going to give her a harder and longer labor because what needs to happen is once that infant gets down there, it has to pick up its head to get under that anterior pelvic bone. And if you're facing this way, it's okay. This way, we might want to turn this and turn the mom a little bit to turn the baby. And this way it's going to be a little bit harder and longer. And that's where you hear people say they've had back labor because that infant is hitting against the maternal spine as it's coming down through. So just like this is right occiput anterior, so this is left occiput anterior. Left occiput transverse, maternal pelvis is left, and left occiput posterior. So the chin is called the mentum. So you can see right mentum anterior. So these are kind of freaky when the kid comes out, his eyeballs are wide open and staring at you. That makes it for a difficult labor as well sometimes. Okay, now if we look at the bottom ones, move it a little bit. There you can see, so this is breech, butt is breech. Okay. Now, babies can be born breech, sure they can, but not without um, questionable complications. Remember that the largest part of the infant to delivered is the head. So we would prefer that the head come through first and then the body can follow. It just kind of falls out. But what can happen is, and which is very serious, the cervix can close up around the head when it gets to delivering the head, and the baby can get stuck there and suffocate. So we would hope that um, if it is breech, that she either delivers quickly because she's going to end up being a C-section. Is what we normally do here in the U.S. In some countries like Canada, they do a lot of breech deliveries and very successfully. Of course, you have to learn the maneuvers associated with doing a breech delivery if you were the midwife. So here you can see there's different types of breech as well. So and these kids are funny. They come out with their feet still up like this, and you have to wrap them tight so their legs stay down. And then there's a full breech or just a single footling breech. So initially, towards the end of the pregnancy, around 36 weeks, we'll start being concerned about what position is this child in. And certainly, mom can do things to help to change that fetus's position. Sometimes they do, sometimes they don't. Um, um, so we would hope that we could potentially change the position and know what position is the fetus in, especially if it's now delivery time. Okay, so a positive birth experience. So you being the nurse that's there for the patient is going to have a major impact on this mother when she gives delivery. So when she has her delivery. So we want her to have a positive experience. We want to encourage her initially in the prenatal clinic to go to childbirth classes, prepare herself, get all the knowledge that she can to know how to or and have the choices that she needs to make to have a positive birth experience and delivery. So there's a lot of things that we can do as nurses too. And it's a good idea to know how you can help your patient. So you can take courses and be observant and assist your patient throughout that delivery process. She'll thank you later, trust me. Um, so contractions. So I'm just going to talk briefly about contractions. Contractions are a muscle tightening. If you've ever had a Charlie horse, well, that's actually a muscle contraction. But with uterine contractions, they start slow and maybe in the lower pelvis and feel like cramping, and they build over time and become stronger. So they might start here where where the abdomen is soft and it becomes firmer. And this is the acne or the high point of the contraction where it's the firmest, and then it goes away. We want to have a resting period here in between. We don't want to build up, and that's not good. We'll talk about that later too, where we could potentially have rupture of the uterus if contractions are too close together. What's important, what I only want you to start with, is knowing that to measure true contractions, you have to have your hands on the patient and palpate a contraction. So, for those of you that have never done that before, when you're assigned to labor and delivery, if your patient is contracting, I want you to ask her if you can put your hands on her belly because you need to feel what a contraction feels like. And not just sit there and look at the monitors because the monitors are basically a guesstimate. They're not a true picture of what contractions really are. A true picture of what contractions really are is to palpate the contraction and listen to the mother. What is she telling you? So it starts here and of course it ends here. But to measure contractions, you measure from one contraction to the next. That's how long the contractions are, okay? One contraction to the next. So we're counting how many minutes apart they are. So remember we did talk about some of those early signs of labor, which is lightening. Lightening is most noticeable with the first time moms. That baby really drops into the pelvis. Braxton Hicks, or practice contractions as I call them, she might start having the nesting, all these things. We already talked about that. Oh, wait, let me go back. Yeah. Yes, okay. Cervical ripening. That's when the provider checks the cervix and it feels soft. It really feels soft. There's some pliability in there. And of course, we've lost the mucus plug or bloody show. You might have a little bloody show, little red flecks in there when that mucus plug comes out. It's like stringy egg white. Sorry about that for breakfast. And this is spontaneous rupture of membranes. Sometimes a sign of labor is, oh my goodness, her water just broke. She's not contracting at all, but her water broke. So in sometimes that water breaking is obvious, splish splash, and my shoes are wet, and other times it's not. There's just a small trickle. And a Bishop's score. Um, Often, well, what we look at these things, this is the provider is the one that does a Bishop score, and they look at the position, the consistency of the cervix, is it effaced or thinned out, how far dilated, and is the head down, and what's the presenting part. A position or a Bishop score, each of these are given 2 points each, 2, 4, 6, 8, 10. So a Bishop score of 8, let's say, that's a good Bishop score. That probability that this mom is going to deliver. But most importantly, what we use a Bishop score for is if we're going to bring the patient in for an induction of labor. We want everything to be right for an induction of labor. So if we're thinking about induction, we want the head to be down, the cervix to be soft, there's some effacement and dilation in the uterus, and this baby to be down low, the fetal station, and the preventing part to be the head, right? So those are all important to get a positive induction that she's going to deliver vaginally, and we induced her. However, you don't find the physicians at the hospital using the Bishop score, not at this hospital. Other hospitals they do, but this is going to give you a more accurate picture of, is this induction going to be successful? All right, so we talked about true labor and false labor. You can read those. And remember, I said that the real difference is there cervical dilation and is she making progression? So this here shows you dilation and effacement. So before labor, this cervix down here, the opening or the doorway is really thick and closed. Thick, very thick. Okay. But as that's your dilation is closed and effacement is thickness. So here it's starting to thin out and maybe open just a little bit, right? So this is a first time mom. That's what it's showing. And then complete effacement, which is thinning out of this here, thinning out of the uterus, and then complete effacement and dilation. So, and this is a multip. In other words, this is not her first baby. Oftentimes, it'll start, the cervix is already zero, or fingertip because she's had other babies before. So never, the cervix never really goes back to its closed, tightly, thick and closed. And this process happens a lot quicker, effacement and dilation, if it's not her first baby. It's the first ones that take the longest to go out the outdoor. Nothing's been through there. Everything has to stretch out, and it's a long, slow process. But once that's done, well, the second baby, well, be careful, you could come flying out. Hello, world. Okay, so we talked about the first stage of labor. And there's three phases in that first stage. The first stage is 0 to 10 centimeters. So that early phase is also called the latent, where the cervix is closed and goes to 3 centimeters. That takes the longest part. And then there's active. Active labor is the cervix is actively changing uh, a centimeter an hour. So she goes from 4 to 7 centimeters. And transition is 8 to 10. And 10 centimeters is, like I said, complete dilation, how far the cervix has to be dilated for the fetal head to pass through. So some signs, you might have some back discomfort, frequency, urinary frequency, because the baby's now sitting on the bladder and using it like a trampoline. Dilation, yes, it's slow, but it's still happening. Shoot, 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 shoot. Okay, where were we? Let's see. So the latent phase, oh shoot. Okay, so in that early phase of labor, uterine contractions are irregular. They might feel like lower pelvic cramps. And however, over time, they will become closer together, more frequent, but they're still irregular. They might start out at 15 to 20 seconds. Mom might notice them or might not. So what this means is it's takes a longer time for that cervix change if this is the first time mom versus it's not. The progress is slow, and mom might be really happy and excited because it's about time. I'm ready to get this baby out. Often you hear that too. The active phase is the cervix is actively changing. A centimeter an hour would be typical. Depending on medications can make a difference as well. And we'll talk about that. Uterine contractions become more regular. They're lasting longer, 30 to 60 seconds. And you can, with each contraction, what it does is it pushes that infant down just a little bit more. And of course, you can't get through labor with absolutely no pain at all. Don't let anybody kid you. You can't. There's an increase in pain, and it's all about each person goes through labor differently. Some can handle it well, and some cannot. So we're all individuals. That transition can last anywhere from 60 to 90 seconds, or sorry, contractions can last 60 to 97 seconds, but they're much closer together. They're much more uncomfortable. And mom just, usually at this point, she's saying things like, I want to get this over with. I'm tired of being pregnant. I don't want to do this anymore and I want to go home. That would not be unusual for to hear her say that. And usually when I hear patients say that, I know they're in transition. So transition is like 7 to 8 centimeters. So she's almost done there. I'd say something like that to her. 8 centimeters. Oh yeah, you're almost done. You're almost to the end. Don't give up now. And anytime that you hear a patient, a patient with a baby in her belly, and she's saying, I have rectal pressure, then you'd best be checking her because the head's probably coming. As that fetus comes down into the pelvis, it pushes against the rectal area, and that's what gives mom that urge to push. And so if that rectal pressure is pretty strong, you better get your gloves on and be ready for delivery. Oftentimes you'll have some back discomfort, maybe nausea and vomiting. And transition is the phase that's probably the most difficult one where patients lose control. They're screaming at you. What the effing you think you're doing to me? Get the hell out of here and get out of my face and don't touch me. So they're not their normal selves, okay? And that does go away, by the way. And so because they're having a difficult time. So let's say she's pushing. Well, we don't want her to push too soon, though. We want to make sure she's completely dilated, because if not, then she can actually tear the cervix and swell the cervix if she starts pushing too soon. So we look for those signs of transition. Like, is she feeling that rectal pressure? Does she have that urge to push? Some people can read their bodies very well and they know, and they'll start pushing when that baby hits against the rectum. Okay, so pushing can take anywhere from 1 to 3 hours, 4 hours. It depends. It can take 20 minutes. It can be a cough and a sneeze. It depends on how far baby is down in the pelvis when she starts pushing. Okay, so baby might just be at 0 station when she's fully dilated. So she's gonna have to, her body's gonna have to do a little work to get that baby to come down to the +1, +2, and +3. Pushing and crowning. So she push when she feels the urge to push, and crowning is when we see the top of the head. You can start seeing it. It's a dime, it's a nickel, it's a quarter. It opens up slowly. And pushing feels good. Patients actually like to push, but there's a right way and a wrong way to do it, and I talk about that later. So one of the things you have to do if you're the nurse there, this patient is pushing, well, she might seem like she's pushing really hard and she's pushing good, but is she making any progress? So the only way to know is she making any progress without checking her too frequently is to look at the perineum. You can see the head of the baby bulging against the perineum as it's coming down. You can see the vaginal opening dilate. You can't look inside, you can feel inside, but you can see the vaginal opening dilate. So is there blood and body fluids coming out? There should be if she's pushing. So that's how we know if she's pushing correctly. If not, well, then maybe we need to get her in a different position so she pushes more effectively. Because otherwise, she's just wearing herself out. So it could take anywhere, like I said, from 1 to 3 hours, maybe even 4. I've had patients that it took them 3 hours. They were just exhausted, and doc says, well, it's been 3 hours. I'm going to take you for a section. And she's like, hell no, you're not. And she'll just muster up all of her energy and push that kid out. So you'll see that too. So from 10 centimeters to birth of the baby. So then we have placental separation, and that can take up to 30 minutes. we don't want it to take too long. Remember what is happening here. The placenta is separating from the uterine wall. So we don't want it to take too long. Um, she'll start having a little more bleeding, and you'll see the placenta come out. It'll rise up, and then you'll get a gush of blood and everything. Whatever you do, because nurses often end up delivering babies when doc's not there or can't get there. It depends on the size of the hospital. If you live in and you work in one of the outlying hospitals, it's a smaller hospital, let's say. Well, doc might be 30 minutes from the hospital, and he's the only doc on call for that night. You get at a bigger hospital, of course, you have doctors all around you. But I tell you, I've done my share of deliveries, so you have to know what to expect and do not pull on that cord. You can break it off, she can hemorrhage, and you've got to go up in with your hand and grab the cord so you can get it so she does not hemorrhage. So it can take up to 30 minutes for that placental separation, maybe 45 minutes at the most. Whoever the nurse was for the mom is also doing vital signs on her. And for the baby, we're keeping track of what time did that baby deliver. So for the placenta, we also need to know from the time that the baby delivered to the placenta, what time did that placenta deliver? How long did it take her to deliver it? Because she could actually be, at risk for infection, right? Here it just shows you a picture as that placenta is detaching here, okay? And you'll start to see it rises up and comes out of the pelvis. Whoops, here I guess is where it starts. You'll start to see the bleeding and more. And so, yes, remember I said you need to look at that placenta. So the most crucial time for mom where she's at risk for hemorrhage is at that fourth stage of labor, which is 1 to 4 hours after delivery. So we take her vital signs more frequently. She's going to be thirsty. Sure, she can eat, and we want her to drink. So she's at risk for atony. And remember, I said that's when the uterus is boggy. So she's usually down in labor and delivery for an hour after delivery. And what they're checking is they're checking the fundus, make sure it's hard and firm. So you do have to look at your policies. How frequently do we do the patient's vital signs after delivery? Do we check her fundus? We can also teach her how to massage and check that fundus. The best thing you can do, however, is have her put baby to breast and let her breastfeed the baby, because remember there's nerves that run from the breast to the uterus that allows that uterus to contract. We want to keep track of blood loss. Anything between 250 to 500 cc's is okay, but 500, but 500 and over for a vaginal delivery would be a hemorrhage. If she had 500 after delivery, that's not going to be good if she continues to bleed and lose more. So you looked at the signs and symptoms of shock, I believe, in Nursing 111, so know those. That would be an increased pulse rate, right? And the patient usually becomes lightheaded and dizzy. Okay, so she'll continue to have contractions, mild contractions, however, after delivery, and that's a good thing, actually. It's expected that she'll have some chills just because of hormone changes. And directly after delivery, remember, we need to keep track of how much urine is she putting out. It's only a one-time deal. In other words, we want to make sure she can put out after delivery. So within 4 hours, she should have voided at least, the minimum is 250 cc's. Okay, a one-time void of 250. After that, you don't have to keep track of I&O anymore. You just have to keep track of, did she void and has she voided yet. So, your mom, she might have had some trauma during the delivery process. So make sure that we keep track of what her vital signs are. Is she having any pain? Because she can have medications for pain after delivery. Usually, if it's a vaginal delivery, it's ibuprofen. If it's a cesarean, it could be Percocet. So it depends on what kind of delivery she had. Whatever the medication we give her depends on what kind of delivery she had. Okay. So these are all important things you want to watch for after delivery. So this is as that infant moves down into the pelvis. So it does these movements, and actually I'm just going to show you here. Should be able to watch it. If it doesn't come up, you can. There it comes. Okay, so it's sideways in the pelvis. It's all flexed. You can see it turn. Look at the molding in the head. This is showing dilation and effacement as the infant comes down. Okay. Watch him turn, internal rotation. Got some molding there. There he goes. He's got to get under that pelvic bone. Lift his head up under the pelvic bone, looking for the outdoor there. Got to get the shoulders under. There we go. And then push off, expulsion. Woo, jump for joy. There we go. All right. See if I can get out of that now. Oops. I think I did. Yep. There we go. So those are called the cardinal movements. Descent, as it descends into the pelvis, it curls up and flexes inward. Internal rotation, well, it's got to get its head underneath that anterior pelvic bone. Extension as it lifts its head up. Restitution, external rotation, and expulsion. There was a thing that I found, a mnemonic, and don't anybody take this as being offensive. It's just a mnemonic, as we call it, to help you to remember what these words if you needed to do it. So this is what I was told. Every darn, whoops, let me go back. Every darn fool in Egypt, eats raw eggs. That's how somebody told me. Anyway, if you can, I'm not going to ask you about the cardinal movements, but somebody else might on a test or an exam. Okay. What's the most common position for labor and birth? Well, back in when I first started practicing, we would strap the moms down and put their legs in the stirrups and their arms up. Now I call it more like the gas pedal mode, okay? There's semi-fowlers sitting and their feet are down and separated. A lot of times I see the nurses holding mom's legs up and stuff like that. I don't do that. I'm too old for that. The best position for labor and birth is actually upright and squatting. It brings the baby down with gravity. And the worst position will be lying on your back because it presses against that superior vena cava. And that's not a good thing. So remember we talked about evaluation and assessing your patient when they come in. We're going to look at their history. You're going to actually do a physical exam on your patient head to toe. We can do Leopold's maneuver. And remember, Leopold's maneuver can tell us the position of the fetus. Is it head down, sideways? Which way is it lying? Whether or not she ruptured her membranes. Is she leaking any fluids? We can do a litmus test, which is a piece of paper that we put on the amniotic fluid, and if it turns dark blue or blue, it is amniotic fluid. However, there's a confirming test, because sometimes it'll be positive, but the nitrazine, which is what we take a bit of that fluid, put it on the slide, the provider does this, and if it has a ferning design, when he looks at under the microscope, then yes, it's amniotic fluid and she ruptured her membranes. There's lab studies we can do. And of course, we're going to assess and evaluate uterine contractions by palpation as well, and a sterile vaginal exam. So those are things we do to assess our patients. To assess fetal well-being, we can listen to heart sounds, uh, evaluate the fetal position. We don't want it to be breech, right? And we do use electronic fetal monitoring here. This shows the external monitors that she doesn't look comfortable, that we hook mom up to. This is the Toco, which picks up uterine contractions, and this is the ultrasound down here where must be fetal back, and we listen to pick up the fetal heart rate. So that's external, but we can also do internal as well, remember, to monitor both of those. So the causes of pain in labor, yes, there is reasons to have that pain in labor. Everything stretches slowly, basically. Okay, dilation of the cervix and all that. Uterine hypoxia depends on how the infant's positioned in the uterus too. I mean, all this takes time, and it doesn't always feel good. Okay, so psychologically, how the mother responds to that pain can make a difference. If she's scared to death, she's tense, she's uptight, she's not going to make progress very fast. It's going to be very slow to come. And so we want to teach her things to relax her and help her to rest as well. Rest is important in the early part to allow the things to change. The more relaxed the patient is, the faster the labor will go. And cultural influences make a great deal of difference here as well, what she's accustomed to. So ask her about those things. So as I already said, we did this one already. Okay, did that one too. So fetal heart rate tracing, that's something we're going to learn in our number 5 lab. So the only thing I want you to know is, if you go to labor and delivery, look at these fetal monitoring strips. The one on top is the fetal heart rate, and a normal fetal heart rate should be between 110 and 160. And these here, these are contractions, and we measure contractions from the beginning of one contraction to the beginning of the next. That's all I want you to know for right now. We go into it in more detail later. So just look at those strips and see if you can tell what it's about. And actually it changed from 110 to 160 the last several years. And we'll talk about variability and fluctuations. Those are all things that we're going to talk about later. And I don't want you to worry your head about them right now. But you do have this written so you can refer back to it when we start talking about it. So these are maybe some potential nursing diagnosis if you were in labor and delivery: pain related to the process of labor and birth, right? And maybe she hasn't, this is her first time baby, so she's never been in the hospital before, and maybe she didn't go to childbirth classes or any of those other things that they offer. So you might be her coach right then, and have to teach her things that she can do to get through this labor. So, okay, so these are all different things that we'll need to be doing as well. Okay. So right after delivery, risk for fluid volume deficit related to increased blood loss. It could be your number 1. Okay. Nursing interventions, we want to be aware of what we're doing. Everything you do for the patient is actually an intervention. Make sure your patient should receive oxytocin after delivery to cause uterine contractions and decrease uterine bleeding. Okay, and all of these should be documented. Here we go. All right, there we have it. We'll go into more and more detail as we proceed in the course. Thank